Hello everyone, it's Dr. Halim Jafar. I'm periodontist, and we just started to present a series of lecture on periodontal diseases, periodontology in general actually, and we started from the history and examination. Before we start, I'd like to ask you to subscribe to my channel, HL Talent, to get more videos on these subjects. Actually, in the previous lecture, we talked about the social and medical history. We talked about these two subjects, and today we are talking about the examinations, indexes, and evaluation. So, basically, in the examination, we have two types of examination during history taking. We have extraoral examination and we have intraoral examination. The extraoral one, a careful extraoral examination may reveal important signs that are associated with the periodontal problems. For example, a severe periodontal abscess can lead to facial swelling and a regional lymphadenopathy. Also, sometimes you may find prominent maxillary incisors that make a lip seal difficult, and this may aggravate the existing gingivitis, which will lead to dry mouth. That's why it will act as an aggravating factor, not a causative factor. So we are checking for lymph nodes, TMJs, and the texture. The texture, we mean by the texture is the texture of face, because we are checking for scars of previous operation, for example. We are checking for the color of the face. For example, we check if the patient have a yellowish face, or a reddish one, or congestive dark blue one, which each one of them are maybe an indicative of the underlying disease. And the lymph nodes, that will indicate an active, if there is a lymphadenopathy, indicates an active inflammation. Also in the TMJ, we check for the opening of the TMJ. If you have a good opening or a limited opening of the TMJ, if you have a clicking, crepitus sounds, etc. So this is mainly the extraoral examination. While intraoral examination, a record should be made of local factors that predispose to the accumulation of the plaque. So we should take a report for a plaque retentive factors, because we know that the main causative factor of periodontal disease is a plaque. So we should check for the plaque retentive factors, and we should make a scoring method which named dichotomous scoring methods, with scoring the plaque and bleeding of the 4 or 6/16 of each teeth. And this is important because it gives you an overview of the amount of, not of the amount of a disease, but amount of bacterial aggregation. And the bleeding score will show you the activity of the disease. If it is still active, you have a bleeding, and not all the bleeding indicates that there's a gingivitis or periodontitis. And also in the intraoral examination, we should check the dentitions through a specific scoring method, which is a basic periodontal examination, in which we have 5 codes that indicate, each of them indicates a specific condition, and we will talk about the basic periodontal examination later. So we will check for the gingiva, for the mucosa, oral mucosa, and we check all the oral cavity for any swelling, any lumps, any bruising, any ulceration. So the intraoral examination is very important, and one of the ways of examination that we are using is by using a periodontal probe. Most of our scoring, the bleeding score, the Plaque score, we are going to use the specified type or specific type of periodontal probe. Here we see a WHO probe in which we have a ball of 0.5 millimeter, then a white steel area which is till the black band is 2 millimeter, and there we have 3 millimeter here, and 2 millimeter here, and 3 millimeter in this segment. So overall we have 11.5 millimeter from the WHO probe. The probing should be undertaken systematically on each tooth to determine the probing depth or the presence of bleeding or the extent of attachment loss. So the probing is important. The probe should be moved gently around the sulcus to avoid trauma, and the force of approximately 0.25 nanogram is recommended, but this is difficult to achieve consistently without the use of pressure sensitive probe actually. But a specialized clinician is needed to do appropriate probing techniques. And an attempt should be made to probe along the contour of the root surface, although interproximally, and it's necessary to angle the probe slightly to reach the side directly beneath the contact area. So you shouldn't use completely parallel alongside the long axis of the tooth. You should slightly angulate the probe while using it during examination, and maybe we show you this technique in another lectures. And this side should be probed from the buccal and the lingual aspects, since deep pockets frequently develops there. And we may face a lot of factors which may cause an error in measurements during the probing taking procedure. And the errors include that we may face depends on many factors. One of them is the thickness of the probe. The more thicker, the less delicate and less sensitive probe you have. Also the contour of the tooth, any irregularities, any grooves, any projections may affect actually the probing technique. Angulation of probing. Wrong angulation may lead to wrong measurements. Pressure applied. Too much pressure sometimes causes spontaneous bleeding by yourself, and it's iatrogenic one. It's not a bleeding due to gingivitis or active inflammation in the periodontium. So the amount of pressure to be applied is very sensitive. You should be aware of that. And also calculus deposits, because the calculus deposits play an important role in inhibiting you from inserting the probe. And sometimes we do, when we have a huge amount of calculus, we do a preliminary diagnosis with the calculus present and not letting us to insert the probe in all of the areas. And after that, after removal of the calculus in the first session, we recheck the examination to find out if there's any pockets, any pathological deepening of the sulcus. So this is important. The extent of inflammation is also important. A probe will more easily penetrate the pocket epithelium and the adjacent connective tissue when the tissue are inflamed. But when you have a strong periodontal ligament attachment to the root surface and you have a good periodontium, you see that there's a difficulty of penetrating the gingiva. A probing depth measurement is influenced by these factors that we talked about. And a more precise assessment of the degree of periodontal destruction is made by measuring from the cemento-enamel junction to the base of the pocket. So, while doing probing for assessment of the attachment loss, we should make a cemento-enamel junction as a guideline for our measurement. And this gives an approximation of the loss of connective tissue attachment to the root surface. The loss of attachment is easier to measure when there has been gingival recession and the cemento-enamel junction is visible. But if you have no visibility of cemento-enamel junction, you may face some difficulty. That's why probing methods need a specialized one to be undertaken. When patients are being monitored longitudinally before and after treatment, sequential attachment level measurement can be made relative to a fixed point. For example, if we don't have an appropriate visible cemento-enamel junction, we may take another and the fixed point on the tooth surface, like incisal edge or cusp tip, or etc. So you should have, in the measurement of the attachment level, you should have a fixed point to measure from. About 20 to 30 seconds after probing, each side is re-evaluated to determine the presence or absence of the bleeding from the base of the pocket. So you haven't to hesitate and be quick in examination. Why? Because the bleeding needs from 0 to 30 seconds to appear while you are probing. So you should do the probing of all of the surfaces, then returning back and checking the sites of active bleeding. Bleeding is simply a consequence of the trauma caused by probing the epithelial pocket lining and connective tissue. Bleeding on probing has been implicated as an indicator of active disease. Nowadays, bleeding is the major and the only indicator for the presence or absence of gingivitis. Longitudinal clinical trials, however, suggest that bleeding has a low sensitivity for disease progression, but there is a controversy regarding this. So, let us talking about the indexes. This is basic periodontal scoring method. This method depends on the community periodontal treatment needs, and this is a quick method for determining the conditions of the periodontium, and it's based on 5 codes, and the oral cavity should be divided to 6/10, like that. This is from canine to canine. This is from first premolar to last molar, excluding the third molar. This is from the upper right as first premolar to the last molar, excluding the third molar. and likewise the other ones. As we said, we have 6 extent and 5 codes, and we have an asterisk symbol at the end. Let us talk about each of them. We have code 0. In the code 0, we have a healthy periodontium. We have no bleeding, no calculus, no overhang filling, and there is no pocket. The sulcus is normal. It's from 0 to 3.5 millimeter. So here the treatment is just motivation and oral hygiene instruction. While in code 1 we have just bleeding, but no calculus, no overhang filling, and no any other plaque retentive factors. And here also we don't have a pocket, and then we have normal sulcus from 0 to 3.5. And the treatment here, when you have the code 1 in all of the 6 tenses, so you just need to have a motivation, a good motivation and oral hygiene instruction to your patient. While in score 2, here you don't have pocket, but you have maybe supra or subgingival calculus or both of them, and you have mostly or mainly overhang filling or any plaque retentive factor like for example partial impacted tooth. We have badly fractured tooth associated with the soft tissue, and we have ill-fitted prosthesis like crowns and bridges, and etc. So in this case, the treatment, when you have, for example, here 2, the treatment should be motivation and oral hygiene instruction and plus scaling and polishing for the removal of calculus. In score 3, we do have pocket. We have a pocket from 3.5 to 5.5 millimeter, and the black band here of the WHO probe that we talked about is partially visible, indicating a pocket of, for example, between 4 to 5 millimeter from 3.5. If you have WHO probe, you can measure it accurately from 3.5 to 5.5. And for the other probes, you lose the ball of 0.5 millimeter. You should measure it roughly from 4 to 5 millimeter. And here the treatment is the treatment of the previous one, motivation and oral hygiene instruction, scaling and polishing plus routiplaning. Here we need a routiplane because you have a pocket and part of the root are affected, the cementum are affected. We need to plane these dead cementum. So in the code 4, we have pocket more than 5.5, and the black band is entirely within the pocket and it's invisible. And this roughly indicates the pocket of 6 millimeter or more. Here the treatment is motivation, oral hygiene instructions, scaling and polishing, plus routiplaning, plus surgical interventions, because here when you have a score 4, you have an extensive progression of periodontal disease. And when you have just score 4 in any segment, you should entirely examine the whole dentition. And one of the important notes here is that you just measure the maximum score. The maximum score should be measured here because this is what the system is dependent on. So if you have, for example, score 4 from first premolar to the last molar, just one score 4 in one segment, and all of them are 0 or 1, so you should write down the 4-1 because the highest score is measured. And this asterisk here, it indicates the furcation involvement in the bifurcation or trifurcation areas. So this, for example, here you have a pocket more than 6 millimeter, with the furcation involvement. This is specifically in the bi or tri-rooted teeth, because the furcation involvement will affect these teeth. So this is a basic periodontal examination. We are going to the indexes, the Plaque index, the oral hygiene indexes. I just explained some of them for you to know how to measure the Plaque on which basis, and oral hygiene index on which basis, and a small hint on the calculus measurement. We have many indexes actually. This is what present in the main textbooks. The Plaque index, if you have a 0, there is no Plaque, and if you have score 1 Plaque index, the film of Plaque seen with disclosing solution or by running probe along the surface. You can't see it by naked eye directly. Well, the score 2, there's moderate accumulation seen with naked eye. With the score 3, abundance of Plaque in pocket and on tooth surface are present. And we will score the 6th surface and all of the 6 surface of how many teeth. For example, you just examine a 6 teeth, 6 multiplied by 6 surface, 36. So 36, the measurements are added and then divided by the 6, which is the number of teeth examined. And this is another way by Quigley and Hine of Plaque index, but the Sillas and Low is the most prominent one. And we have oral hygiene index. Oral hygiene index, it scores the debris and calculus as separate component. In 0, there is no deposit. In 1, not covering more than 1/3 of the exposed tooth surface. And 2, coronal deposits more than 1/3 but less than 2/3 of tooth surface. Individual flecks of subgingival calculus can be seen. And 3, deposits on more than 2/3 of the tooth surface and continuous band of subgingival calculus. The scoring here made on the facial and lingual surfaces, and record the worst score over the sextant index equal to total score over the number of sextants. And we have a calculus index by Volt-Manhold. The height and width of the calculus is measured with a graduated probe along 3 planes on the lingual surface of 6 lower anterior teeth. Any calculus score 0.5 mm index is the sum of the individual measurements divided by the number of scores made. So these generally the main index of Plaque index, oral hygiene, and calculus one. We talked about simply in the basic periodontal examination, we talked about the asterisk symbol of the furcation involvement. Here we are talking about the classes of furcation involvement. We have a curve explorer is used to determine the topography of the furcation involvement, and this kind of probe is named neighbor probe. It will allow the accurate classification into 3 groups or 3 classes or 3 grades. In the grade 1, the tissue destruction doesn't exceed more than 3 mm or not more than 1/3 of the tooth width into the furcation. So here you can feel the furcation, but it's totally covered by soft tissue. But you can feel by the probe. Well, in the class 2, horizontal loss of periodontal support exceeding 1/3 of the tooth width, but not encompassing the total width of the furcation area. Not all the furcation area is included with the disease, so there is no through-to-through passing of the neighbor probe. While in class 3, a horizontal through and through destruction of the periodontal tissue are present in the furcation area. Here may be associated with the soft tissue recession, and here bone and soft tissue are lost. So this is a furcation. Another index is a tooth mobility. Mobility is assessed by applying a labiolingual horizontal force on each tooth in turn using the handle of the dental mirror. So you use the handle of 2 mirrors to examine the mobility. And the movements are simply scored according to the simple index. Grade 0, there is normal physiological mobility or no apparent mobility, which is calibrated by less than 0.3 millimeter, more in the morning and less in the evening. And we have grade 1 or score 1, the mobility is less than 1 millimeter buccolingually. While in grade 2, the mobility is between 1 to 2 millimeter buccolingually. While in grade 3, the mobility is more than 2 millimeter buccolingually, and we have 1 millimeter horizontal movement. So when you tap the tooth vertical movement. When you tap the tooth vertically, you find that there's a movement because there's no attachment, neither apically nor on the sides of the teeth. So the periodontal ligament destruction made the tooth to be mobile in all of the directions. So this is mobility. And we are coming to radiographic evaluation. Radiographic selection criteria for periodontal disease should take into account the diagnosis made from the clinical examination and the overall state of the patient's dentition. The panoramic radiograph, particularly if obtained using the modern machine, is an alternative to full mouth periapical radiography. So if you don't have a time or a machine of using or taking 14 x-rays, which is a full mouth radiograph, by taking a high quality OPG, it will help us as a full mouth radiograph. In the posterior segment, vertical bite wings are often a useful supplement if a panoramic view suggests bone loss localized to this region. So sometimes the OPG is aided with the bite wing, especially when you have a bone loss, alveolar crest bone loss. Radiographic features that can be identified include pattern of bone loss, furcation involvement, variation in tooth anatomy, overhang restoration, widening of periodontal ligament space, especially in cases of when you have occlusal trauma, or sometimes you may see a periapical infection in case of perioendo lesion. A decreased alveolar bone height on a radiograph is only a historical record of previous periodontal involvement and gives a little, if any, information on recent or current activity. So, when you see a bone loss, on the radiograph, don't think that this is an active disease. The bone loss can be happen within a day and night. It's an indication of previous disease activity, not the current disease activity. And these are regarding the evaluation and in